Hello, I'm Faith Rogers, host of today's program, COVID-19 Keeping Up with a Moving Target. This is the May 5th episode of DKP Med Radio's Coronavirus Educational Series. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC and AAPA credit, as well as AMA PRA Category 1 credits. Please visit our website for complete CE information. If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. Today's learning objective is to discuss the impact of MS and MS disease-modifying therapies on COVID-19 severity. This educational activity is supported by independent medical educational grants from Gilead Sciences Incorporated, Regeneron Pharmaceuticals Incorporated, and Eli Lilly and Company, as well as in-kind support by DKB Med LLC. All activity content and materials have been developed solely by the activity directors, planning committee members, and faculty presenters. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. He will be interviewing Dr. Kornberg, Assistant Professor at the Department of Neurology at Johns Hopkins School of Medicine, as they discuss multiple sclerosis and COVID-19. Dr. Kornberg, Dr. Auwaerter, thank you so much for your time today.
Thank you, Faith, and delighted that Michael could join us today. As we're well into our second year with the pandemic, one of the types of patients I think has certainly been highly affected are people with chronic illnesses. And I'm so glad Michael could join us for one of the illnesses where his expertise is so important. Multiple sclerosis is something where immunosuppressive agents are used. Patients are at risk for their illness being worse during infections and so on. So I think it'd be really fantastic to get some insights that probably are applicable to many, whether it's rheumatologic illness or other suspected autoimmune-based illnesses. So Michael, patients that you've been taking care of. I mean, I'm an infectious disease guy. Short term, cure them, you treat them. Hopefully that works well. Of course, we have our HIV patients, but for your patients, where clearly MS is such a great worry, and there's a spectrum of illness, what kind of things have you seen or problems that you've faced that patients and you have tried to adapt with typical care for this population?
So there have been many issues that have arisen during the course of the pandemic. And as you can imagine, some of those issues have changed and evolved as the conditions of the pandemic have changed and evolved. And they relate to a number of different domains when it comes to patient care. So a big one, especially early on in the pandemic, was how do we provide the sort of care and perform the necessary monitoring, both in terms of their disease and safety monitoring for patients, with the limitations offered by the risks of COVID. And so early on through the pandemic, when we were in lockdown, when the outpatient center was entirely closed, we had to figure out how do we first interact with patients and see them and examine them and get a sense of how they're doing over time. And that's where telemedicine came in very rapidly, and we all had to adapt to that, and patients did as well. And then we had to make some very practical decisions in terms of, we have patients that get MRIs every 6 to 12 months, patients who are on therapies that require them to get blood draws anywhere from once a month to once every 6 months, and how can we change that schedule in a practical way to deal with the limitations of the pandemic without putting patients at risk. And quite frankly, some patients took a step back in certain ways because physical therapy is very difficult to transition to to a virtual setting. And so I think that deconditioning has been a problem for a number of my patients who have more physical disability. And then there's a number of other issues that I think we'll probably touch on later in terms of understanding how some of their immune modifying therapies impact their risk from COVID. And then, most recently, it's all been about vaccines.
Sure. Yeah. So Michael, as we're now well in our second year here, we're seeing patients back in the office. And some of my patients are like, no, I really don't want to come in. I like the telemedicine from my chair and so on, especially in a field like yours where I think the physical exam does count for so much. Uh, how do you sort of handle that? Because obviously some of your patients probably are quite limited and difficult to get into the office. And, how do you sort of make that? Is that an individual basis? Do you let your staff make the decision? Do you let the patients opt? I mean, I think this is one of the thornier issues in our office where, there's lots of back and forth. So and so wants to be telemedicine. Is that okay? And and you said in person, but they don't want to come in. And, I think this is something, at least as long as we're allowed to do telemedicine, I think is going to be a harder area to navigate sometimes.
Yes. So for me, first thing I'll say is, among my group, and then I think even more so, in the Department of Neurology, there's a broad spectrum of approaches to that, from different doctors. My own approach has been kind of a combination of what I think is best for a patient and what the patient wants to do. And so, I do try to have personal control, over that decision oftentimes, and but being as reasonable as possible for the person that I'm seeing. And so, for me, first of all, I appreciate you recognizing how important the neurologic exam is, because it's something we try to drill into the medical students heads still. But for me, it's a matter of for brand new patients I've never seen before, I much prefer to see them in person, because there are elements of the neurologic exam that at least I have not become facile at doing remotely. There's just no way to really assess spasticity and other issues that are important for understanding the extent of someone's disability without laying your hands on them. And so, as a general rule, I've tried to have all new patients come in for an in-person appointment. At the same time, if a patient kind of reaches out and has concerns that something has changed about their function in a significant way, then it's also helpful to have them come in person, and I try to make an effort there. There are, fortunately these days, a lot of very stable patients, who have not had any active disease for a while, who report that, their symptoms are the same. And I feel very comfortable doing video visits with them. And, I've tried to, adapt that a bit based on patient preference, obviously. I've kind of come up with I've made a deal with a number of patients that, let's say I'm going to see you in person once a year, but all the other times, unless something changes, we can do video visits. And I find there's a lot of room for negotiation there, while maintaining, the aspects of care that I think are important.
Yeah, so I think this is something we'll continue to navigate together, and it'll be interesting to see how long we're allowed to have the more liberal use, at least with our in-state patients. On a slightly different topic, as an infectious disease doctor, I know Justin MacArthur and some other of your colleagues have always been concerned that illness might make MS worse or exacerbate their underlying problem, whether it's a urinary tract infection or sepsis. Do you have any insight so far, since COVID-19 is such a peculiar illness that includes immunosuppressive aspects as well as hyperinflammatory responses? Has there been any sense for people who have had COVID-19, how it's impacted their disease?
Yeah, so there has not been a lot of large studies, high quality data around that. So it's been primarily anecdotal for me, both with my patients, but also we have quite a large MS group at Hopkins, and so we all kind of share our experiences. The one thing that we've all seen is kind of this, this pseudo relapse phenomenon. So there's two concerns with viral illnesses in MS patients. So just like you said, really any illness can make existing symptoms worse for people with MS. It's the same sort of recrudescence we see in stroke patients who, when they get sick, something knocks them off their horse, their neurologic symptoms are worse. So that happens, with many viral illnesses, with urinary tract infections, like you mentioned. We've all seen that with COVID-19 as well. So, patients who have been on the sicker side, their neurologic symptoms are worse. Fortunately, just like other cases of pseudo relapse, that is a temporary phenomenon. So there's no really new injury happening to the nervous system. And so as they, get further out from their infection, those symptoms, generally resolve. And we've seen a similar pattern in COVID-19 patients. The other kind of, I would call it maybe theoretical concern, because it's not well established in large studies, but again, anecdotally, you see it with a variety of viral infections, is that there's a concern that it can actually trigger the immune system to produce true MS relapses, new lesions, new injury. I can't say that any of us in our group have seen that among our patients, fortunately, and it hasn't been studied well, at a larger, registry level. So it's difficult to say, whether that might be the case, but at least anecdotally, fortunately, we haven't seen that.
Well, yeah, that's I think very helpful, because certainly, high risk factors for severe disease, people often list neurologic conditions, and there have been some case control studies and so on. Are patients with MS in particular, do you think they fall into a higher risk category because of COVID-19, in that, with that large group that just says neurologic disease?
Yeah, so it's all about disability as far as I'm concerned. So I don't think that MS just by itself makes you high risk for COVID. So there's two elements to that question. What is the risk of COVID for their neurologic disease, and what's the risk of their neurologic disease on their course of COVID? And at this point, I don't think we have any good reason to think that COVID is particularly dangerous for, let's say, exacerbating or triggering relapses for their neurologic disease. And so I tell people that MS by itself is not does not make you high risk when it comes to COVID. But on the flip side of that, in terms of how MS or neurologic disability in general impacts the course of COVID, there is some good evidence there. And so, I know that evidence around MS the best, but there have been several large registries. The largest that's published to date included about 840 plus MS patients in Italy who contracted COVID. And there were clear risk factors for having a more severe course of COVID-19. And those were, not surprisingly, age, and disability and duration of disease. And so, I think it's really just a matter of frailty. And so, in the same way that older patients are at greater risk from COVID, patients with greater physical disability who aren't as mobile, who are generally more frail, certainly, late stage patients, who might have any respiratory compromise, they are certainly higher risk for COVID. But MS, just as a blanket statement, is not, in my view, a high risk condition.
Yeah, of the sort of diseases that might have an immunological basis, does MS seem to sort of, I mean, for people that may not be as familiar, I don't have any, I still do some primary care, and just trying to understand, where that might land. I mean, there's some people that have peripheral neuropathy problems, for example. Is there something that's a little different about MS, do you think, versus some other immunological conditions, just in terms of maybe where this pandemic is, or just in general?
Yeah, so I don't think MS is likely to be much different, than other, let's say, autoimmune conditions, both of the nervous system and, other systemic, conditions, rheumatologic conditions. Uh, maybe rheumatologists would disagree with me, but, in my general sense is that, all of these conditions, that are really kind of dependent on the immune response, they generally all behave fairly similarly in the context of infections or insults in general. And so, I don't think that, someone with a autoimmune, peripheral nervous system disease is really going to behave differently. And, same with rheumatologic condition. I think, what's different is the symptoms that might get worse in the context of getting COVID. So, it's kind of like anything that knocks you on your horse, just makes your existing symptoms worse. And so those symptoms are going to differ based on the disease. And, also in terms of what risk your disease has in terms of your course of COVID is going to depend on, what your existing deficits are. But I kind of imagine them all behaving fairly similarly because, ultimately, there's an autoreactive immune response, and it's just a matter of, what the target is in the body.
It's a concept that I think patients and even some doctors don't quite grasp or come to the wrong conclusion. I think, of course, every patient is special. Every type of disease is unique to some degree, but so often people think, oh, I have a weak immune system, I'm going to be especially prone to COVID-19, when really most autoimmune diseases are immune systems that are ramped up more than they should be. And so people are asking, oh, should I get in a specific immune workup to make sure that I don't have a deficiency. And this is a very common infectious disease question, but I'm just sort of wondering, even amongst your patients, I mean, the number of people that I think feel like they have an immune defect, but that its weakness is usually fairly substantial.
Absolutely the same, among my patients, and I would say, the first 3 months of the pandemic, my the patient messages I got were pretty much almost split in two, between people who felt that they were high risk because their immune system didn't function properly, and so they wouldn't have an adequate immune response to COVID, and the people who were worried that that COVID might make their MS symptoms worse. And so I've had exactly the same experience, that a lot of people just have this understanding that their immune system is dysfunctional, but not necessarily the direction of that dysfunction.
Yeah. So, Michael, I really want to thank you for your insights. I think trying to help patients with chronic medical problems, but especially when they're of an immunological nature and you're using immunologically active drugs, are always so challenging. So really appreciate that. And in our next segment, we'll be tackling immunizations in patient populations such as multiple sclerosis. So please stay tuned for our next episode.
If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. Any questions or issues, feel free to email us at the address listed. To submit questions, please send them to qa@dkbmed.com. That's Q as in question, A as in answer, at dkbmed.com. Again, thanks for joining us, and thank you for your dedication to your patients with COVID-19.